go ahead and transition over to our patient access bill. That is House Bill 2078. And Matt Friedlander, I'm going to turn it over to you. Matt, if you could do a little bit of an introduction about who you are and how you started working on this bill, and then maybe talk a little bit about the bill itself.
Yep, absolutely.
Thank you.
Yeah, my name is Matthew Friedlander. I own Skagit Organics. We're a licensed cannabis company here in Washington State. I have been on the board of the Alliance for 6 years or so. Joined the Alliance as a member about a year or two before that. I've sat on the patient committee on and off for the last several years, led by John Kingsbury, who's joining us today as well. So thank you, John, for leading up that committee. Um, so this bill came out of some of those conversations, along with our experience as a company here in Washington trying to get medicine to registered medical cannabis patients. It's not an easy thing to do the way that our system is set up. Our company occupies a little bit of a unique space here in the industry. RSO is the main focus of our company and our products. We make ourselves very accessible to the general public, to our customers and to patients. And in that process, over the years, we've had many people reach out to us directly, looking to get specific things from us. To make that happen, I then have to figure out what part of the state they live in or where they're willing to travel to, because that patient is going to have to go into a retail store to purchase those products. My company is not allowed to sell those products directly to the general public or to patients directly. So I've got to coordinate with buyers or management at the store to send something specifically, for a specific person. We've got to organize it with them so that their staff knows to hold this product until that person arrives, or the store needs to contact that person directly. It's just not a straightforward, easy process to go through. So, um, through some of that experience, some of these ideas came up, and again, through some of the conversations that were happening in our patient committee. A lot of the things in here, before we crafted this bill, I did present this to John and the patient committee, and it's been through several other people here at our board at the Alliance, and I'm sure there's been some other eyes on it as well. But these are the ideas that we've come up with now that we've got the excise tax removed. We've seen an uptick in patient registrations. We've seen an increase in medically endorsed stores, and we've seen an increase in um, DOH compliant product. All great things. One of the big complaints that continues to arise is frustration from the retail stores as to how time consuming and onerous this process of registering patients at the store can be for them. They have to employ a licensed medical cannabis consultant. That person needs to be available to the public for a certain set number of hours. That's got to be advertised to the public as well. But for a registered patient to become actually entered into the database, they need to be able to connect in person with one of these consultants at a retail store for them to be able to take their authorization that they have received from their medical provider to get entered into the database. On the other side of that, we've heard from patients who are having a hard time being able to find these consultants in the stores at the times of day or hours that works for the patients. Sometimes a store may only have one consultant on staff, and that person may only be in the store part-time. Or the patient may not live near a medically endorsed store. We've got, somewhere in the range of 500 stores. Last I looked, I think there's 100 or 200 maybe medically endorsed stores. So still lacking access points for patients. still lacking the ability to be able to connect with these consultants. And just the whole process is just time consuming and hard for people that, are dealing with serious medical conditions or have mobility issues, or any number of things. So that's kind of where where the ideas in this bill have come from. Yeah, and Fortuna commented that the stores might have a consultant on staff, but they may not even issue the card or know how to or have the things needed to do that. So again, yeah, just continues to be a frustrating experience for everybody involved, I think. So the bill, let's see, and Caitlin, was there do you want me to drop the link to
There
the bill in there?
Yeah, so I put into the chat a link to our one pager. I did notice a small little mistake, so we're good. Today is also a great preparation for us as we're getting ready for the legislative session. It does say at the top SB 2020 the numbers, but it should be House Bill HB. We'll get that fixed. However,
Yeah,
everything else on there is correct. Thanks, Matt, for putting a link to the bill itself. That
yeah.
is also linked on that PDF.
Excuse me. So the bill is titled An Act Relating to Expanding Access to Medical Cannabis Consultants in Department of Health Compliant Cannabis Products, and amends a number of different RCWs. Um, so I'll start at the beginning, I think, of the process of how someone becomes registered as a patient, and work through the ideas that we have and the changes in this bill, through that direction. So currently, someone looking to become a registered medical cannabis patient um, has to visit a medical provider. That medical provider has to authorize them for the use of medical cannabis. There is a list of qualifying conditions that this patient must meet. Um, and then the patient has to then take that authorization to the store, to a medically endorsed store, and find a medical cannabis consultant who will enter them into the database. So this is the first place that we're trying to streamline this process. This bill would give the option and the ability to these medical providers that are issuing the authorizations to just enter the person into the database at this time. Um, Most medical providers already have the ability to, they've got support staff, or they've got access to the Secure Access Washington platform, which is, we call it the SAW platform, that you need to be able to, that you get permission from the state to interact with the database. So the bill would allow the option for this to happen at the time that the authorization is provided. This would just reduce this would reduce the number of trips that a patient's going to need to make. Take the entire process of having to then go find a consultant at a store while the consultant is there and get entered into the database, on the, usually out in front on the public facing floor of the retail store. So that's the first big change. Um, the next change would involve expanding the practice parameters of these licensed medical cannabis consultants, to include allowing them to provide consultations and registration to the database remotely. So currently, in the way that the law is written, these consultations and entry into the database, the way it's worded, it seems to indicate that these have to happen at the retail store in person. Um, Again, people with mobility issues or are dealing with some severe, medical conditions might have a hard time making this trip, even though they just made the effort to go visit their medical provider. They now got to go to a store, and make a second visit. So it would allow the consultations to take place remotely, similar to something like telehealth. The proof provided to be entered into the database from the patient to the consultant could be either mailed or emailed or presented just as a picture on the remote consultation. The consultant would then be able to enter the person into the database and mail that person's card to them. The big fear here, we had this conversation with the Department of Health, is that there might be, some issues with fraud or people misrepresenting their authorization. But I believe there are safeguards in place that we can, that are safeguards that we can put in place that would, discourage this and make that non-existent. I think there's already room for fraud in this process, anyways, or misrepresentation, and so I don't think that's a um, reason to not let this move forward. Um, so then I believe that the next big change would be allowing processors to employ and work directly with medical cannabis consultants. The other part of expanding the practice parameters for a medical cannabis consultant is that right now they are tied to having to work with a retailer. So this would allow medical cannabis consultants to also work with producer processors. It would allow the consultant to have their own standalone business. If someone wanted to make a go of offering consultations and could turn that into a business model of some kind, this would allow for that option as well, so that medical cannabis consultants could operate on their own outside of any licensee. Um, I see a couple questions coming through. I'll get to those here in a minute. And then, so this would also expand, excuse me, everyone, fighting a little bit of a cold over here. This would also expand the medical endorsement to a processor, which would then allow a processor to sell DOH compliant product directly to a registered medical cannabis patient. So this would provide a few more access points to patients that, again, may not live near retail stores. This would remove some of the burden from the retail stores, of the administrative work of doing this. Again, we've heard from, several retail stores that it's very time consuming. Maybe their, consultant quits or moves to a new location. There's just a number of reasons why this would be, I think, beneficial for everybody involved in this system. So, um, and I think those are the big main changes. Um, Let me just scroll through the bill here a little bit. Yeah, I think those are the real um, main changes to the current process. Um, if I missed anything, John, Kaylin, feel free to jump in. Um, But then we do have some questions. So Fortuna asks, telehealth would also put patients with more specialized needs to access consultants who are more familiar with their condition as opposed to a consultant who has less specific knowledge. Sure. Yep. That would be great. Yeah. I mean, I would like to see a little bit more. Um, I would like to see more of this, I think, probably happen at a more fully fledged medical provider level than, again, at the consultant level, at the retail store, um, you know, in front of other people that might be shopping. A lot of patients probably don't want to have to talk about severe medical conditions with four or five other people in the store. So there's some bit of a privacy issue here as well that this helps solve. Um, um, and then Mike's asking, how about a nurse that's trained in ECS and regs? Um, yeah, I mean, I think I'm not quite sure exactly who's able to provide these authorizations. But yeah, we can definitely look into whether this would allow the expansion to some degree of allowing medical providers that aren't currently on that list to be able to provide those? That's is a good question. How many producer processors medically endorsed? There is no medical endorsement for producer processors right now. What we do as a processor is we take extra steps to test our products for heavy metals. Um, and at Skagit Organics, we go even further and we do DDT testing on all of our products. But to get a product certified as a DOH compliant product, you do the normal I-502 testing, which includes a number of things, but does include pesticides. And then you add the heavy metals test. And I believe there's one or two specific pesticides that they test for there on top of the normal I-502 pesticide panel. The DOH does keep a registry of medical cannabis patients. Um, do they allow UW nursing for research? I am not sure. I don't believe, John, you can probably answer this. I don't believe they allow access to that database for research purposes currently. Yeah.
They can do it if things are de-identified.
Okay.
They have to be separated from
From any
any sort
patient.
of personally
Yeah.
identified, and then they can actually.
Okay.
Um,
And
there's
I
a
then
don't,
question
I
there.
am not aware of that having happened here in Washington State just yet. Are you, John?
What?
For the de-identified information being used for research.
WSU has done it.
Okay.
Yeah.
uh,
So
okay.
this
Thank you.
was a couple years back. I don't know what it was they were doing, but um,
Thank you, John.
I think
Um,
that's. Oh, go ahead.
No, I was just saying, yeah, and then Fortuna's saying, yeah, patient privacy is a huge issue. The only store I know of that has a private space, I believe, is Novel Tree down in Bellevue.
Right.
Um, I think a few others may have added those recently, but yeah, that's the only one I'm aware of. And then Mike, yeah, thanks for clarifying. Nurse practitioners can certify patients or probably provide the authorizations, is what he's saying. I guess I will hold for any other questions, or John, if you would like to talk about this or your process in helping shape this or the conversations you've had around this bill, feel free.
Well, I think you captured an important tone, which is, um, there are patients who do want help, and the retail stores are sometimes not conducive to that. I mean, most of this, what they're selling is recreational products, which is great. That's where their bread and butter is. So,
Yeah,
I know there's been a number of times where people have asked me about, say, a customized RSO. I don't know how you handle labeling in that situation.
sure.
How do they do that?
I mean, if we were going to follow all of the rules to the letter of the law, yes, there would be several barcodes on that package if we were going to be blending oils together. Um, I think, have enough varieties that we don't have to do that any longer. I think we've got enough different kind of formulations and combinations of cannabinoids through the products that we make. But that may not be, that's not the case for every company out there. So yeah,
I'm a strong believer that cannabis is terribly underutilized as medicine. And I think the environment that it's offered in and the lack of serious help are big parts of that.
yeah, absolutely.
And I don't want to tell you how to run your business, but if it were me, I would probably, when this bill passes, I'd probably make some contacts with healthcare providers. So
Yeah,
instead of sending some some person into the store, they can send it to somebody who is focused on the health, the
yeah,
medical part of it.
yeah,
So I think that'd be really useful.
yeah. And I mean, it would take some stress off of me, John, if you did want to tell me how to run my business. Might be nice.
Well,
Um,
until it went in the tank.
yeah, No, yeah, it's one thing that we run into a lot. Like, we know our products better than any of the medical
Right.
cannabis consultants that work at the stores, right? We know our stuff better than anyone else in the state. And so what we do currently, is we'll advise people on a number of different things and um, of what they should look for. We do sometimes recommend products that aren't ours because we don't have somebody wants a tincture or something that we don't make. And so we do try to find what is going to work best for the patient and send them into the retail store armed with as much information as we can give them so that they can just walk in and say, I want that, and that can be the end of their interaction with the stores. They don't need to rely on someone who's maybe out of the loop or just doesn't have the same information that we've got. So yeah, I would love to be. It's a big goal of mine to be working more directly with a number of different medical providers and institutions in the next year or two.
In
Yeah.
the back
as- oh, go ahead, John.
back in the good old days, we used to network with neurologists and ontologists, or oncologists, excuse me.
Yeah.
An ontologist is a philosopher. So,
I was just going to
um,
say that's an interesting field of medicine.
yeah,
Also useful still.
Yeah, also
yeah.
useful. What I'd
Well,
like to
anyway,
do before we move into talking a little bit more about strategy and some of maybe what opposition might have to say about this bill, and what sort of story we want to make sure that we're telling to the legislature when we do get to a hearing on this.
right.
This bill was filed during session last year, but it was after the cutoff for the policy committee, and so we sort of debated on whether we wanted to do pre-filing or just go ahead and get it filed. And our recommendation was let's get that done now. So while it's been out there, we haven't had a hearing just yet. I do want to flag we don't have incorporated in policy boot camp. The compassionate care bill that's going to be coming out. So I just wanted to take this time to say a little bit about that. And we'll probably borrow a little bit of home grow time, John, too.
Hmm.
But I think that's okay too, because I think that's
That's fine.
the one we've been
Yeah.
talking the most about for the longest. But the compassionate care bill, we don't yet have a number for that. Like I had said it in the opening session, that's based on Ryan's law, which was passed in California. We spoke to Ryan's dad. Ryan was a young man who was a teacher actually here in Washington, was diagnosed with pancreatic cancer, and I know that one personally really well. And if you do too, you know that it's one that goes once the diagnosis happens, it goes pretty quickly, and especially in young folks. And Ryan actually passed away here in Seattle, at Swedish on Capitol Hill. And when I was talking to his dad, he and I had a good cry together about folks that we've lost, and then also sort of talked about, when Ryan was put into the hospital and put on all of the management meds that people are put on at end of life. He was sort of out, zonked. It was, a lot of opiates,
Mm.
wasn't able to have conversations, and pretty much slept the whole time. And when they moved him out and at home, and then I think through their hospice, they were able to find a way to get him cannabis, replaced a lot of those sedative medicines that they give at end of life, and instead, his dad said we lost about a month to those medicines, but we got 3 weeks at the end back, because once he started using cannabis instead of those sedative medications, his pain was managed fine, but then he was also awake and capable of seeing friends and family in those final days. Ooh, and even talking about it now, I'm going to get a little bit choked up, because it is so powerful. And it's such a shame that so many facilities are resistant to it. We have a letter from, I was going to say HHS. That's not the right one. John, what is it? The Medicare, the federal government, basically saying a lot of resistance from facilities for allowing cannabis use in there is that their concern is that they receive federal funding, and that they're worried about losing their federal funding if they allow for this access. We do have a letter from the federal government saying that they will not pull funding if folks at end of life are using cannabis is one of their therapies, which is a huge deal. And so we sort of expect this not to be one of those 7-year lift bills, but one of those bills that we can move through pretty quickly. Representative Kloba was sort of exploring expanding it beyond just terminally ill patients. I think the more that we've been talking about it, however, I think a fast passage of this very sort of narrow scope to begin with, Al talking about those half loaves is probably the right way to go. And then we can start talking about expanding who that applies to on into the future. Does anybody have CMS? Thank you so much, Lotta. Um, Anybody have any questions about Ryan's Law or the compassionate care bill?
I haven't seen that in a pre-file. Have you?
Nope, it's not ready yet. And I think it's that component of, I think what the sticking point right now is expanding who it applies to versus end of life only. Yeah, thanks, Mike. The Association of American Cannabis Nurses Association. I forget what the two A's are on the other end. But Cannabis Nurses Association, I know has been working with Ryan's dad. There's a version of this bill in just about every state that has adult use cannabis, and or medical cannabis. I think we would be the second state though to actually pass it if we got it through in this session. And I know that, thank you, American Cannabis Nurses Association has been working closely in support of this. And I believe there was a study, Mike. I don't know if you've seen this. I haven't seen the study just yet. That was put out because it's been in effect in California, I think, for 2 years now. Sort of looking at whether or not this caused any problems for the facilities that allowed it, and showed that there's been no disruption of care at all whatsoever. So the only impact has been wildly positive for the families that have had better end of life. Okay, maybe Oregon. All right. So, what I would like to do, we have just a little under 10 minutes. I think I'm going to give it 15 minutes. What I'd like to do is spend a little bit of time talking about strategy. So, we do expect that we are going to get a hearing for this bill. And this is now like the full audience participation side of things. We do know, to begin with, that a little bit of resistance we're going to get on this bill pertains to the onset, the direct sales from medically endorsed producer processors to patients. That opposition primarily comes from retail stores who are concerned about losing their business. And I would like to start a little bit of a discussion about, just at first blush, hearing that. I'd love to hear from folks in terms of what do you think is a salient argument for why this bill is still a good idea, even if it's perceived as being a threat to retail stores. I know, John, you've already been thinking about this, and I see your hand. I want to leave a little bit of space if anybody else has some thoughts. And it's okay if this is a little slow. This is our first strategy session of the day, but we're going to be moving fast by the time we get into the second one. Let's see. I see in the chat. When did retail stores begin to care about medical patients? Fair enough. Jamie, number of patients to rec consumers is still low. I would agree with that wholeheartedly. John, last time we looked, we're still not even at 15,000 patients in the state of Washington. And then I'm not sure what percentage of those would be wanting to work direct instead of just being able to go into their store. The idea here would be, of course, to expand the number of patients. We know that there are certainly more than 15,000 patients in existence in Washington state that would qualify for this. And so this is another effort in making sure that patients get the medicine they need without having to pay that sales tax. But yeah, I think that's a good one, Jamie. Um, yeah, I'm
Yeah.
Fortuna's got her hand up.
Yeah. Go ahead, Fortuna.
I think that there's already clear exceptions in the law around how excise taxes are charged, proving that this is medicine. And like, it would be very strange if they passed law, like, if they controlled prescriptions in this way, it would not make sense. And it's clearly for medicine if we aren't charging taxes on it. Like, we're already treating it legally as medicine. And it's very, very strange to me how, like, specifically controlled it is versus the recreational market. Like, the recreational market having these controls makes sense because it isn't treated as medicine. But like, if I can get on telehealth and get stimulants from any provider in the state, basically, why do we have these controls around marijuana in a way that is only hurting patients, basically?
Yeah, 100%. I've got a weird echo on somebody's computer. Is everybody else here? Was anybody else hearing that echo? Oh, no, I think it's gone. All right. Yeah, and then Mike in the chat, I need specific strains that are rarely found in stores. I think that is also another really compelling part, sort of that bespoke or custom. I know even Matt, I've got a patient in my household. We've talked about, two things that I can get and then mix together to sort of get us to a better treatment level. And so what patients' needs are for a store to actually carry the wide variety of potential needs for a patient is sort of an unreasonable ask for that kind of shelf space. And so being able to go directly to the producer or to the processor would save shelf space for higher volume traffic, and then also make sure that patients are getting the medicine that they need.
And again, to waylay these fears, as much as, I would want to take advantage of being able to sell directly to patients. Currently, I don't think my building's not currently ADA accessible. I would have some upgrades to make. There's going to be zoning issues for producer processors. Some of them aren't going to be located anywhere near where anyone is to want to come buy anything anyways. Um, there's going to be a number of things that are going to need to happen for a processor to be able to take advantage of that side of things anyways. And again, it's going to be for currently 15,000 people total in the entire state. Um, so it's just, it's again, it's one of those things like how many providers are going to enter people into the database if they have the option to. Maybe not a lot, but at least that option will be there for the people who do really need it and really want it.
Mhm. And so when we know that we've got a challenging piece to, some legislation, even though that, for all of the reasons that we've talked about here, what we also then start looking towards is testimony. And what kind of testimony do we need to give to the legislature? A little bit about testimony. In the policy committee, they want to hear everything as it pertains to the piece of legislation when we get up there. And so this is about always constituents telling stories that matter. And so in this case, I'm just sort of curious, is anybody having any ideas about who would be good to testify? What kinds of stories do you think would be good to testify on this bill to help tell that story?
I think if we put a face on it I think this is a niche market. The people who will really benefit from this, I think, are a small slice. So people that want products mixed, which a store can't do, um, or they need very high doses over a period of time. You're talking about cancer patients. You're talking about epilepsy people. Those are the stories we want to tell because those are the niche. They're they're high in need, and they're poorly served by the current system. And those are the people who are going to, let's say, frankly, make a trip to a processor instead of doing the convenient thing and going to the local store because their need is high. And I think that those are two things we want to emphasize, which are the unusual need that just can't be served in the store. And, if you got people who are, they need, think of people who are doing, half a gram of RSO a day. And there are those people. Those are the people we want up, I think. You're frozen on me, Caitlin.
Am I?
Oh, now you're better.
Okay. I maybe have just been listening quietly. I get accused of.
No, those are the stories because you're talking about showing people who are high in need and different in nature from other customers.
Yeah. I see, Mike. I see your hand up. Go ahead.
Yeah, thanks, Caitlin. Sorry I tuned in late, but this is very, very interesting and timely. I'd be willing to testify. I testified as a nurse down in Oregon, and over a period of 10 years, starting in 15. So I learned the ins and outs of who to do and how to do it, and but based on medical, primarily medical. And that was a uphill argument for a while. And then finally, a couple key legislators, like up here, Kaloba, she reached out to ACNA, and that's why we're involved. Now, I'm the only one in the state that I know of that in the ACNA that could contribute here, but I'm sure we could do some zooming and the idea on what Oregon did was basically extend what they had, but I don't see that here. Having to piecemeal this thing is certainly frustrating, but I totally agree with what John said. I mean, the formulations are key. Don't have to wait till we get pharmaceuticals or Schedule 3. Schedule 3 would be helpful for research, but what we're doing right now, I've done with retail stores, but it's very difficult to find the strain of need. Very difficult to happen to find a really good bud tender is also a medical consultant, and that helps. But that's over at Buddy's in Renton, and they're really good. But that's probably the exception more than the rules. So maybe use that as a model. I don't know. But the other thing I noticed was no space to do this in the dispensary. Um, so, that's maybe why, doing it remotely is just what they're doing in medicine, remote. Remote's, people have been trained now in remote for the last few years. So that's a real way to do this if they'll allow it remotely, patient consultations, maybe the first one in person, whatever. But, um, that's what I want to do is really get the patients help.
Well, and I think you're touching on then too another prong of our testimony. Yeah, is hearing from consultants as well as also providers for those other parts of the bill around being able to print authorization cards and provider offices. And so we'll want to let the legislature know that that's something that's desired. But then also, yeah, this remote component and accessing medical cannabis consultants outside of the context of a store. We know a couple of medical consultants who have worked in stores, but then also have sort of developed an informal relationship with patients outside of that context, and or have sort of developed materials like a blog post or small meetups that are well within the law, however are providing a little bit more close care for patients who need something more than just having their card printed in a store when they're there to get the to get the best thing that they can find while they're there.
Yeah, and usually cases like cancer, you know, um, that's very convoluted a lot, and it depends on the providers. And I don't want to spend a lot of time talking about that, but that's my kind of niche is case management. So it includes, medical review, medicine review, you name it. And nurse practitioners, like I said, can certify. So if they can do it remotely as the quote providing physician, and we're going to have less hills to climb, I think.
All right. I am loving how this conversation's going. Thank you, Fortuna, for also putting your name in the ring for a potential testifier. We are, I think, going to wrap up this section. Matt, is there anything that you wanted to add here at the end?
I don't I don't think so. I think there's a lot of good ideas swirling around in the comments, and um, I was excited. I actually didn't notice that Wiley's name was on the bill as well.
Yes.
Um, Cloba and Wiley, so that's fun. Um, but yeah, I think the only thing I would say is to is as fun as it might be to steer away from um, bashing the retail stores too much during this process. Um, there are, for as much frustration as people may have with them, we don't want to lump everyone in together. And I don't think it helps our cause to, um, maybe antagonize that group of folks as well.
Okay.
So,
Thank you so
yeah.
much for saying that, Matt. I couldn't agree wholeheartedly. We have some excellent retail partners that care
Yeah,
deeply about patients and are serving them with care and consideration.
yeah,
Um,
absolutely.
and again, I think you hit the message, John, on the head, which is, this is a sort of primarily for a niche market of folks that are different from the average person who goes into a retail store, and really will meet a true need there. And it's not necessarily that stores aren't meeting that need for, plenty of folks, and or that there aren't stores that are trying really hard to do their best in the confines of the way that the law has been written. This isn't about retail stores doing a bad job. This is about some folks who just aren't able to get what they need in that context.
Yeah, I mean, I try not to think about it of taking anything away from the retail stores. We're trying to add options for patients,
Yeah,
right?
well said, Matt.
Yeah.
John, you have a comment?
I'm thinking, I'll tell you who I'm wondering about is Kim Dakota's neighbor. I wonder how he's doing. What kind of, if he's still doing. I would think if you reached out to him, he would be the textbook representation of the person we want to talk about.
Okay, that's a great recommendation. We are sort of wrapping up here. I want to thank all of you. If you wouldn't mind, can I get a raised hands from folks who are here today who really want to make sure we keep in touch regarding these bills moving forward? I know Nathan put information in there for the um, patient caucus where we'll be talking a lot about that, but things are going to be moving fast. All right, I see Dave, Elizabeth, Fortuna, Mike. We'll make sure that as we are having some, further strategy sessions talking about actual testimony, I'll make sure that the four of you are on my contact list to include in those conversations as we get rocking and rolling. All right.